Hello, I'm Dr. Brenda Howard, and I'm here presenting today to the University of Indianapolis Student OT Association on April 11th, 2024. And I'm pleased to greet you all. Sorry I can't be with you there in person today. So, we are talking about vestibular rehabilitation for the entry-level practitioner today. What do you need to know in order to be able to practice in vestibular rehab? Now, that's to say, I'm not going to make you an expert in vestibular rehab just today in one short 30-minute session, but I am going to help you open your eyes to what kinds of things you might see in practice that ought to trigger you into this person is having a vestibular problem. I need to get them to someone who knows a little more than me to be able to address their vestibular issues. So we are looking at, and I'm using as the basis for this presentation, the AOTA position statement on vestibular rehab. This position statement's been around for a long time. It's actually just about to get updated, and it provides the basis for what can OTs do, what are OTs qualified to do in vestibular rehab. So I really recommend you taking a look at that document. So hopefully, after you look at that position statement, you'll understand that you can articulate the expertise occupational therapy practitioners have in addressing vestibular rehab and understand how you are distinctly positioned to understand, intervene, evaluate when vestibular impairments keep a person from their desired occupations. So what is balance anyway? What are the components that make it up? Well, we know from way back in our neuroscience course that it has to do with what we feel through our feet, what we hear, not hear, but feel through our vestibular system in our ears, and what we see with our eyes. And in fact, our eyes make up a very large part of our balance system. But the second thing that we rely on after our vision is going to be our inner ears for knowing where we are in space. So the vestibular system is made up of a lot of different components, and we're going to do a quick review of those components. Now, you remember you've got your outer ear. That's the part that we can see all the way into the eardrum. Then we've got the middle ear, which is the part that gets plugged when you have a cold. It's also the part that has those three little bones that transmit the sound from the eardrum to the inner ear. And then beyond that, about an inch inside and right behind our ear, like if you feel that mastoid bone, and if you went in about an inch, you would see the vestibular portion of your inner ear, or the vestibulocochlear part, because the hearing part is there as well. The vestibular part is no bigger than a dime. It's a really small little component that's inside of your skull in there. So this is what the vestibular system looks like. Of course, the curlicue part is called the cochlea because it does look like a snail's shell, and that's the hearing organ. I won't be talking about that today. And then we have this vestibular component. Now, you may remember that we have these three semicircular canals on one side, three on the other side that sit in all the planes of motion that help us to sense where our head is at in space when our head is moving. And those little ampullae contain the vestibular organs that help us sense what that is. We'll talk about those in a moment. And then we also have in the vestibule the utricle and the saccule that help us sense linear motion, like riding on the moving walkway in the horizontal plane or riding the elevator in the vertical plane. So here's that otolithic membrane that helps us sense what's going on in our inner ears. You may remember hearing people talk about the fact that there are rocks in your ears, and that's those otoliths that are stuck down in this gelatinous membrane, kind of the consistency of honey. It's thick, kind of stiff. And then underneath that are these hair cells, these hair processes that, whether they're bending one direction or another, help us to sense which direction that motion is going. We have these hair cells in the utricle and the saccule. And then we have in the semicircular canals, the cupula, which helps us to sense acceleration and deceleration of our head. Now, another thing that we may want to remember is that there are tons of vestibular connections, so that when we have vestibular problems, not only do we see problems with understanding where we are in space and how fast and how far we're moving, we can't manage our eyes. Now, one of the things you'll notice with these connections is how interconnected the vestibular system is to our ocular system. Hence, we get the vestibulo-ocular reflex. The vestibulo-ocular reflex is what keeps our eyes on target when our head is in motion. The thing that lets me keep my eyes on you when I'm turning my head is not my eyes. It's my inner ears telling my brain how fast and how far my motion is going. Now, typically, that is what we call a gain of 1, meaning that it's 1 degree this way for every 1 degree that my eyes go that way in my head. So 1 over 1 would be a gain of 1. So if my head goes 30 degrees right, my eyes go 30 degrees left, 30 over 30 is 1. That helps keep my eyes where they belong. When we have a vestibular problem, we may not be able to maintain that gain of 1. We may have a lag, we may have an overshoot, and that can mess up our vestibulo-ocular reflex, which can really throw us off. Not only does it help us, not help us keep our eyes where they belong, not keep our head, us knowing where our head is in space, but it can make us feel really crummy. Because if you remember with these connections, we also have connections to the vomiting centers. Okay, we have connections to our cerebral cortex, so we have a cognitive awareness of our movement, and we also have cerebellar connections, which help us manage our balance. So all those things are going to be off if our vestibular system input is not being understood correctly. Now, there are a variety of reasons why it may not be understood correctly. So these are some of those central connections of the vestibular system and how important those are. And we've already talked about the vestibulo-ocular reflex. Similarly, we have a vestibulospinal reflex and a vestibulocoelic reflex, so that if we tilt our head in space, our brain knows that we need to right our spine in a certain direction in order to keep our head and eyes upright. Limbic connections also mean that we have feelings about our movement or the lack thereof, the ability to understand where we are in space, which is why sometimes people with vestibular problems can have such raw emotions. And then the autonomic connections, again, relating back to the vomiting and nausea that people can have. So what do people say they have when they have a vestibular impairment? Well, first they might say vertigo, which the true meaning of vertigo is a sense of movement where there is no movement or an illusion of movement. In fact, when people are looking at busy patterns like on this slide, it can really leave them feeling very uncomfortable because their brain does not know what to do with that input. What about dizziness? Well, dizziness is sort of a generic term, sort of a catch-all term for the vertigo that we might have, also combined with the lightheadedness and the imbalance that we may have. So people, when they have a vestibular impairment, will also say that their vision is blurry. Why? Because their inner ears are not stabilizing their eyes on their target. So rather than get a nice crisp image, it's like they're looking through a shaken camera all the time. It's that vestibulo-ocular reflex that keeps us from feeling like we're looking through a shaken camera. So if that's impaired, then we can't keep our eyes focused on the target. If people are also complaining of a hearing problem, you can know pretty much that that vestibular organ itself is being impaired, both the vestibular system and the cochlea, and you want to get them to an otolaryngologist right away. You want to get them to an audiologist and have their hearing checked. So this is where it's a good point for remembering that we need to refer when possible. What about cognition and balance and coordination and emotions? Yes, those can also be impacted by vestibular problems. Cognition, whether it's a peripheral problem with the inner ear itself or a central problem with the connections or with the brain or with the cerebellum, it can affect our ability to think. Why? Because of all those connections that the vestibular system has, one of the things that happens is that the vestibular system, when it's not operating in the background, when that information has to come into the foreground and we have to use our conscious awareness to know where we are in space and kind of override all that ugly background noise that's happening when our vestibular system is off, that using of our cognitive space, if you will, means that we don't have enough room in our working memory and our working cognition to do our normal tasks of daily living. So people start to say things they're like I walked into a room and forgot what I was doing. I tried to say my grandchild's name and I forgot what it was. These don't necessarily mean that there's a central issue, but we do need to be aware that, hey, this could be an indication of maybe there's an undiagnosed stroke. Maybe there's a brain tumor that we're not aware of. We need to be thinking of, if people are reporting of cognitive symptoms in the midst of vestibular symptoms, We take care of the vestibular issue first and then pay attention to, are there still the cognitive issues remaining? Of course, balance and coordination, and again, those raw emotions that happen because of the limbic system connections. So what are some of the causes? Very simply, breaking it down probably more simply than it ought to be, we have peripheral issues that can happen with the inner ear organ itself, which even though it's in our head, it's a peripheral organ, or central issues like cerebrovascular accident, migraines, which are a central condition, can cause vertigo, and concussions or any kind of traumatic brain injury or post-traumatic brain injury syndrome. So peripheral causes, we have things like unilateral vestibular hypofunction. This can happen to one inner ear because there's a virus or an injury. Something happens to that inner ear that causes usually a sudden change, so that it used to be that the vestibular information is coming in equally. Now one side is not producing information and it's below the other. So it produces this asymmetry. This can come from a labyrinthitis where the labyrinth itself gets an infection, neuronitis, and guess what one of the most common causes of that is? It's the herpes virus, just like cold sores and things like that you can get from that herpes, or even the varicella, the chickenpox virus, almost like a shingles that happens to your inner ear. You can also have an inner ear stroke. You can also have a tumor. So there's lots of times when we don't know what's going on in there and we need to ask someone to get this diagnosed. If we are suspecting a vestibular impairment and don't understand where it's coming from, we want to refer them to someone like a neurologist or a neuro-otologist or an otolaryngologist who can find out what in the world is going on in that inner ear. And there are tests that can be done with audiologists to the vestibular portion of the inner ear to help us understand exactly what's going on. So oftentimes when it's peripheral, people will report a sudden onset. There's an illness or there's a trauma or there's something that's unknown, but they woke up one morning and they had to crawl to the bathroom and they were vomiting. It's usually constant dizziness that's provoked by motion. So it's worse when they move, but they have it all the time. So head and body turns especially cause it to be a problem. They also can't watch movement or patterns. Crazy carpet, crazy patterns on your shirt can really make them crazy. It really bothers them a lot, makes them feel dizzy because of that vestibulo-ocular connection. They also have what is really mild to moderate imbalance. They feel very unbalanced. They feel it a lot worse than what it really is. They feel like they can't walk down a hallway and turn their head without putting their hand out and touching the wall. But they're not falling over with their balance. They're able to catch themselves. They know something's off. What about central causes of vertigo? Migraine-associated vertigo usually happens with the migraine onset. It can occur without the headache pain, and it's usually very transient, okay? So migraines, they come and they go. They can last 12 to 24 hours, sometimes longer. And the vestibular can be a prodrome, or it can be something that happens after they have a migraine, but vertigo can be something that goes with a migraine. Post-concussive disorder, again, can be part of causing people vestibular problems. And CVAs, particularly cerebellar and pontine strokes, can cause a lot of dizziness. Now, your middle cerebral artery strokes, the more common brain strokes that were, like circle of Willis types of strokes, we don't usually see as much vertigo, although we do see some balance issues sometimes. Okay, so vestibular migraine, talked about this a little bit. Doesn't have to have the headache with it. Usually discussing it with the person and finding that they have a history of migraines when you're doing your occupational profile can help you start to be thinking that direction. Does this sound more like a central problem or a peripheral problem? Their symptoms are very similar to a unilateral vestibular loss, but there's no objective findings and it's very transient. It may be present sometimes and gone at other times. They also, a big hallmark of this is that they're motion, light, and sound sensitive, just like other people with migraines. It can be episodic, it can come and go, wax and wane, or it can be present, most of the time. It just gets a little bit better at sometimes. Typically, your vestibular migraines don't respond to the usual vestibular exercises that we give. They more respond to gentle things like balance, Tai Chi, those sorts of things, gentle yoga, habituation types of exercises. If you remember, habituation means just teaching our brain to get in the habit of tolerating certain movements and exercises. Post-concussive disorder. Now, this can be a tricky one because people can have, from getting a big whack to the head, both central and peripheral inner ear problems. They might have a concussion. They might also have labyrinthine trauma. They might have benign paroxysmal positional vertigo, which is a specific kind of vertigo that happens when people change their positions in space, typically lying down, rolling over, looking up, looking down, angular motions with their head. Because that gets right in those semicircular canals. And that's a very specific kind of vertigo. Sometimes those people aren't dizzy at all the rest of the time, but they're dizzy with those head motions. So that can happen with post-concussive disorder along with all the other kinds of vertigo. They can also have headaches, cognitive problems, imbalance. They can be motion sensitive, visually sensitive. So just about every kind of vertigo that you can have might show up when you have a post-concussive disorder. CVAs look similar but different from the concussive folks. With CVA, you sort of have this low hum of vertigo going on all the time, always feeling dizzy. Maybe gets a little worse with motion, maybe gets a little bit better when they rest. But typically, they're a lot more imbalanced than your folks who just have the peripheral type of vertigo. They also may have lost which direction is up. They have sort of lost their subjective visual vertical. There are ways to test for this. They also have direction changing nystagmus. Now, we don't have time today to get into all the different types of nystagmus that you look for when someone has vertigo. But if you are doing an oculomotor screen and you notice that when they look right, their eyes bounce right. When they look left, their eyes bounce left. When they look up, their eyes bounce up. That is definitely a central problem. And in fact, any vertical nystagmus that happens just with eye movement, not with head and body changes, is a central problem. And you need to get them to a neurologist who can diagnose whatever's going on. And you let them know, I saw vertical nystagmus with this person when I was doing oculomotor testing. Very important. So what happens with folks that have vestibular impairment? Of course, they're going to have trouble with their ADLs. They're going to have troubles with their instrumental ADLs, including and especially driving. They're going to have trouble at work, looking at screens, phone screens, computer screens, iPad screens. They're going to have trouble when they have to change their position of their head and look at people. And they're definitely going to have trouble with social participation. People who were very socially active all of a sudden find themselves wanting to be the wallflower or just staying at home. So if people are starting to talk about those sorts of things and the depression that they get as a result, you know that there's a lot going on, and we need to take a look at that vestibular impairment. So what can you do as an entry-level OT? Well, you can do your standard evaluation and intervention. The way this typically goes with evaluation is you're doing your occupational profile on someone who, say, maybe fell and broke a hip. And you're asking them, well, why do you think you fell and broke your hip? And they say to you, well, I got dizzy. Ding, 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 ding. You should be thinking about, why did this person get dizzy? Do they have positional vertigo? 1 in 10 older adults has positional vertigo at some point or another in their life. So you need to be very, very aware of that. You may not know how to test for that, but you can refer them to a PT or an OT. And I'm all for the OTs, knowing how to do a Dix-Hallpike test to see if they have positional vertigo. Very important. You can have them do self-assessment scales and visual analog and numerical scales of their dizziness, just like you can do a pain scale. You can ask 0 to 5 or 0 to 10, what's your vestibular impairment? You can do your regular ADL and IADL observations, assessments, evaluations, and note down what you see about their dizziness or imbalance. And of course, are OTs qualified to do balance assessment? Why, yes, we are, because balance is a skill that we need every day for our ADLs and IADLs. For intervention, again, at the entry level, we can do functional mobility training for these folks. How can they safely move? How can we compensate? We can look at compensatory strategies to support their performance. And some of the sensory things that we know how to do come into play here. Sensory calming techniques, especially for our folks who have vestibular migraines. So listening to soothing music, going into a dark room, wearing those sunglasses, using glare reduction glasses for computer screens, teaching them to move slowly and not quickly when they have to like look at different screens or things like that. Assistive devices so they don't have to bend over to the floor as much. Looking at home modifications for safety, for fall prevention. Also in their work environment modifications, maybe workstation. I one time worked with someone who we simply moved her printer from behind her to beside her so she didn't have to be turning around all the time to the printer. And it saved her so much in the way of vertigo just by avoiding that movement. Looking at habits and routines and how we might reorganize things, just the good old stuff that we usually do. Educating clients, looking for things online that are appropriate at a couple of different websites that are good for vestibular conditions. Vestibular.org is a good one. The Vestibular Disorders Association that has some good handouts about just exactly what is going on with your systems when you have a vestibular problem. And again, if you don't know, refer them to somebody who does know. That's always a good thing to do. Some of the more advanced things that people who have more training can do, when they do evaluation, they can actually evaluate for the vertigo. They can do some head shaking tests, some repetitive activity tests. There are oculomotor tests, objective tests of the vestibular ocular reflex, benign paroxysmal positional vertigo testing, which is with that Dix-Hallpike test, and then treating them with the repositioning maneuver. Something you should not try unless you know what you're doing. But it's honestly not that hard. So if you're interested, I'd really recommend you go to a 2-day course and learn how to do that. For intervention, vestibular rehab therapy with some specific gaze stabilization exercises, habituation exercises, and balance training exercises, more complex activity analysis and environmental modifications. Also looking into either addressing or referring for the psychological issues that people can have, the limbic system connections that people can have. And another specialty area is vestibular rehab in childhood, which can look very different in someone who never gained those vestibular systems to start with versus someone who had them and lost them. So everything I'm talking about today is not about the kiddos who are having trouble with managing sensory systems, integrating sensory systems, because they never had that to start with. That's a completely different skill set. So I have a case study for you. This is Mr. Jones. He's a 75-year-old male who has a history of cardiovascular disease, diabetes, and smoking. He awoke 3 months ago with acute vertigo. All of a sudden, he had difficulty walking, so now he walks with a cane, and he also furniture creeps. He has blurred vision, vertigo, nausea, falls when dressing. He stopped doing a lot of his desired occupations, playing golf, working part-time. He stopped going out with friends, getting together with grandchildren. When he goes to church, he sits in the back and he leaves early, and he's canceled his vacation. Not surprisingly, he's irritable and depressed. After going to a number of doctors and finally to an audiologist, he found out that he had vestibular neuritis, and now he's referred to you. And what I'm wondering is, what's one thing you would like to test based on the history of the things you know how to test? What would you want to do first? And what is one intervention that you might select? And what's one person that you might want to refer to find out more about what's going on or to treat the difficulties that he's having? That's where I'm going to leave you with it today. I'll let you discuss on your own. You can always reach out to me at howardbs@uindy.edu, and we can talk about it more at that time. So reach out to me with any questions or comments that you have. It's been great today. Thank you for having me, and hope to see you soon. Thanks.